Assistant Professor of Critical Care Medicine in Cairo University in Egypt, and he's talking about the fluids management in burn patients. Welcome, Dr. Khaled.
The pathophysiology and the outcome, it was evaluated that the use of the yearly fluid resuscitation is of a great importance in determining the survival in burn patients. In the early trials, they were thinking about the nature of the fluid and the volume of the losses. They were studying the nature and the volume of the losses so as to evaluate what type of fluid to be used for the resuscitation and how volume. In 1942, during the World War II, this was the first protocol applied for the fluid resuscitation in burn patients. And the hypothesis depends on the main fluid loss occurs from the raw area of the burn skin. Accordingly, the nature of which was similar to the plasma, and they considered the resuscitation based on the burn surface area and using mainly plasma of 1 liter of plasma for every 10% of the burn surface area. When later on, there was a realization that not only the external loss through the burn skin, however, there was also a great importance for the transmembrane shift, which occurs due to the capillary leak syndrome and the increase in the membrane permeability. And accordingly, some other authors provided the body weight burn budget based on the losses is not dependent on the surface area of the burn, but it's dependent upon the body weight, which represents or can be an estimate of the transmembrane shift. And they used also colloid as 7.5% of the body weight. In 1952, the Evans formed the first formula to combine the use of the burn surface area and the body weight, and the use of the normal saline of 1 milliliter per kg%, in addition to the colloid of 1 milliliter per kg% of the burn area, in addition to a fixed volume of 2 liters of glucose in water. This is during the first 24 hours. However, with further studies, there was evidence of that the main problem is the transmembrane shift, and accordingly, the development of intravascular osmolarity, and so the replenishment of the electrolyte, replenishment of sodium in the intravascular space is considered to be more disconnected and reconnected again. Right. So again, following the realization of the importance of the crystalloids in the resuscitation rather than the colloids, the Brooks formula used the 2 milliliter per kg% surface area. 1.5 cc of them were crystalloids, in addition to 0.5 only of the colloid solutions. In comparison of the effect of the resuscitation with crystalloids and the colloids, in response to the hemodynamic response and the estimation of the lung water, it was realized that the volume used with the colloid resuscitation was significantly lower than the volumes required if the crystalloids were used. And also at the 24 hours, the cardiac index was significantly higher when the colloids were used. However, at 48 hours, this difference in terms of the cardiac index disappeared, and also there was a significantly higher lung water contents with the use of the colloid resuscitation. This study done by Baxter was a milestone trial in the resuscitation, upon which the development of the Parkland formula was instituted. This was an animal trial where they evaluated the fluid exchange and the fluid losses in the untreated and the cardiac index in the untreated burn animals, and used the same outcomes with the cardiac index, with the different volumes and modes of the resuscitation. What was very important in this trial is that there was a little effect on the red blood cell mass and the plasma volume with the in the burn compared to the extracellular fluid decrease, which emphasize again the importance of the use of the crystalloids rather than the use of the colloids. The impact on the cardiac index, there was, or cardiac output, there was a progressive decline in the cardiac output reached, which is maximum at 4 hours, and there was a stabilization at 18 hours of about 40% lower than the baseline of the cardiac output. When they used the TOR strategy for the resuscitation, when about 20% of the total body weight were given over the 24 hours, there was a progressive increase in the cardiac output, which will stabilize at about 8 to 10 hours. However, when the half of the volume that was given during the 24 hours were given rapidly in the first 8 hours, there is rapid stabilization of the cardiac output, and from this point later, the resuscitation of the Parkland formula used the 4 milliliter per kg percent. Half of them are to be given during the first 8 hours, and the remaining half over the remaining 16 hours. And as early as in the studies, there was, as Dr. Walid said, the problem of the over-resuscitation or the large volume of administration. In this case series, there are two cases were studied. In the first case, there is administration of large volume reaching about 1 liter, despite an adequate or over-adequate urine output, and this patient developed systemic and acute pulmonary edema, and accordingly, the volumes were decreased, but without adequate response in terms of the urine output, and mortality occurred at 135 hours. Compared to this, in another patient where the resuscitation used about 400 cc with a conservative urine output, despite there is a large gap at the early resuscitation between the input and the output, this represents the replenishment of the volume deficit, and this gap disappeared when the extracellular fluid volume deficit was replenished, and this patient survived. In the same trial, in the same study, when the plotting of the percent burn to the extracellular space expansion percent above the normal, it was seen that when the extracellular fluid replenishment was high, more than 70% of the normal, all patients died. And when it was in about 50%, the patients survived, despite some of them were in the high mortality rate with a burn of 70 to 80%. All these items make the emphasizing the need for more conservative strategy, and accordingly, the modified Brooks formula changed from the original Brooks formula was also 2 milliliter per kg percent, by it was 1.5 crystalloids and 0.5 colloids. Had been changed to be 2 milliliter per kg. All of them are in the crystalloid form, and again, the half of the volume to be given in the first 8 hours. So the main formulas used, the Evans formula, Brooks formula, Parkland formula, and the modified Brooks formula. The most commonly used formulas nowadays is the Parkland and the modified Brooks formula, and they usually stated if the formula is not set, the volume of resuscitation is 2 to 4 cc per kg body weight percent surface burn surface area. The crystalloids used, normal saline or lactated ringers, this is a question which asked in every resuscitation, as in sepsis and the others, and we cannot say it's a normal saline. We again should emphasize it's abnormal saline. With these large volumes of resuscitation in burn patients, usually it causes the hyperchloremic metabolic acidosis, and the use of the crystalloids of choice is the use of lactated ringer solution. In the Evans formula, normal saline was supposed to be used. Comparing both formulas, the Parkland formula and the modified Brooks formula in a retrospective study involving about 58 patients with targeting urine output of 30 to 50 milliliter per hour, it would show that, and this is normal, the volume used for resuscitation in the first 24 hours was significantly lower with the use of the modified Brooks, which stated the use of 2 milliliter compared to the 4 milliliters used in the Parkland formula. The incidence of achieving what's called the AV index, we will discuss later, it's reaching the volume of 250 milliliter per kg of the volume resuscitation. The incidence of reaching this index was significantly higher with the use of the Parkland formula. But actually, these differences were not transmitted into any effect on the clinical outcomes in terms of the development of ARDS, acute kidney injury, abdominal compartmental syndrome, and the mortality. What we should observe in this trial, when the Parkland formula is supposed to have the volume at the level of 4 milliliter per kg, it would actually a volume of about 6 milliliter per kg with over-resuscitation by this amount of volume per kg. The administration, the actual fluid administration in the Brooks formula was near the 4 milliliter per kg of the projected or calculated volume according to the Parkland formula. These volumes represented an over-resuscitation compared to the estimated formula, and they form what's called by some authors as the fluid creep during the burn resuscitation. From this point, some authors try to simplify the calculations for the fluid resuscitation used. One of them is the use of the rule of 10 with the estimation of the burn size and then multiplying it by 10 to detect the fluid rate of administration if the weight between 40 and the 80 kilograms, and for every 10 kilograms above the 80, you will increase by 10 tons or by 100 milliliters per hour. On this formula, the rule of 10 compared to either the 4 milliliter per kg of the Parkland formula or the 2 milliliter per kg of the modified Brooks formula, most of the patients slide in between them with mainly close to the modified Brooks formula. Another simplification done by the French Society of Anesthesia is the publication of the mobile application, which is the eBurn app, through which you will mark the burn area, and the app will automatically calculate the burn surface area from the front of the patient and from the back of the patient. And at the end, when you calculate the whole surface area, you will modify the rate of fluid you want to give from the 2 to 4 milliliter per kg. You will adjust the weight of the patient, and accordingly, the application will measure the rate of fluid administration in the first 8 hours and from 8 hours to 24 hours. You should note that some patient groups have routinely required additional fluid volumes, including the inhalation injuries, electrical burns, and the delayed resuscitation. Inhalation injury patients required injury patients. What clinical outcomes you measure while using the fluid resuscitation in the study done by the Baxter for the development of the cardiac output, but also they targeted a urine output of about 50 milliliter per hour. Some authors use the target of 30 to 50 milliliter per hour, or 0.5 to 1 milliliter per kg per hour, and others were more conservative and targeting 0.3 to 0.5 milliliter per kg per hour of the urine output. But you should note that the oliguria and the low urine output may persist for 48 to 72 hours post-burn, and this may be present despite the adequate replenishment of the fluid deficits. And this might be related to the surge of the antidiuretic hormone that occurs with the stress of the injury. However, some authors considering the urine output as an outcome for the resuscitation might be not suitable. And accordingly, many studies used what's called the goal-directed therapy with the use of the transthoracic thermodilution, transesophageal echo, pulmonary artery catheter, intrathoracic blood volume index, and the other invasive monitors for the patient hemodynamics. What's important in these studies is the studies that compare the use of this goal-directed therapy to the use of the simple urine output, hourly urine output as a target of measures, and they found that the goal-directed therapy in most of the trials was associated with a larger volume of resuscitation, and this was not translated into better survival with the use of the goal-directed therapy. Despite in one trial, there was increased incidence of the multi-organ dysfunction score with the use of the hourly urine output as a target for the resuscitation. In one protocol, there was a change of the rate of the fluid resuscitation by 10% or 20%, increasing in response to low urine output, and again by decreasing by 10% and 20% in response to the high urine output. This is to avoid the over-resuscitation. The problem of over-resuscitation was studied like the problem of the under-resuscitation. The over-resuscitation form was called the fluid creep. In one trial, if you measured according to the Parkland equation, the patient was supposed to have some volume for the first 8 hours. Then it's supposed that the volume decrease, and the same amount given in the 8 hours are to be given in the next 16 hours, and then to be halved in the second day. What actually happened in this patient is that the first 8 hours, the actual volume of resuscitation was nearly similar to the calculated according to the Parkland formula. However, at the end of the 8 hours, despite the urine output was satisfactory in the targets between the 0.9 to 1.8 milliliter per kg per hour, it was supposed that the volume of resuscitation is to be decreased. Alternatively, it was increased. And in response to this increase, there was increase in the urine output, and only the volume of resuscitation decreased in a stepladder manner when the urine output exceeded the target urine output assigned by the publishers. All this volume is considered as over-resuscitation, and this is what's called the fluid creep. In some trials, all the patients included in the trials have resuscitated with actual volumes which exceeds the estimated according to the used formula. The main impact of the use of the over-resuscitation is the development of intra-abdominal hypertension and consequently the abdominal compartmental syndrome. In this study done by AV, and we called the AV index before, in the study, the AV and others do a regression analysis in plotting the used volume of resuscitation against the intra-abdominal pressure. And from the regression equation, it was found that the intra-abdominal pressure of about 25 milliliter mercury was achieved when the volume of resuscitation was about 250 milliliter per kg. And accordingly, they considered that this AV index of 250 milliliter per kg is a critical number where when you reach resuscitation by this volume, it's important, there is a high risk for the development of intra-abdominal hypertension, and accordingly, the intra-abdominal pressure should be frequently monitored at this stage. This fluid creep is speculated by many authors to be due to the inadequate response to the urine output, as we told before. Is when you're supposed to decrease the volume of resuscitation after 8 hours, some physicians increase the rate. The use of goal-directed therapy was associated with a use of larger volume than the targeting the urine output. And one of the main causes of this fluid creep is the overestimation of the burn surface area itself. In this trial, it would suppose that the volume is used, the half of the volume that we given in the first 8 hours. And it would suppose that the second half of the volume to be given in the next 16 hours. But this happened only in half of the patients, with a decrease in the resuscitation volume by 35%. In the other half of the patient, there was increase in the volume of resuscitation by about 47%. So how to avoid or how to prevent this fluid creep? Some authors consider the use of colloids. There is a great controversy with the use of colloids in the resuscitation of the burn patients. The use of colloids in a meta-analysis was associated with no difference in terms of the mortality and in terms of mortality. However, all studies, including the meta-analysis, and the meta-analysis itself showed lower volume of resuscitation when the colloids or when the albumin was used. In one trial published in 1983, there was an increased mortality with the use of albumin. Actually, this study affected the practice with the use of albumin for several years. The use of albumin in the early phase of burn is seen to be deleterious by many authors. At that time, in the first 8 to 12 hours of burn, there is severe capillary leak, up to it might cause leak to the large molecule, including the albumin, and this might increase the interstitial edema formation rather than correcting the interstitial edema formation. So despite that, albumin was seen not to be associated with any beneficial effect over the crystalloid resuscitation in burn patients on the assumption that the albumin is associated with lower volume used during resuscitation, and the edema-related complications are related to the volume of the fluid administration. So theoretically, the use of albumin, which might be associated with lower volume, could be used to decrease the incidence of the edema-related complications. So there are two main strategies when using the albumin to avoid the fluid creep. One strategy is the use of the albumin as routinely at the end of the first 24 hours. The other strategy is what's called the escape. It's used when the projected volume of resuscitation was seen to be exceeding the AV index or exceeding 6 milliliter per kg per cent burn area. When the response to urine output was associated with decreased urine output, causing increasing rate of infusion, and accordingly, when you use the fluids up to reaching the 250 or 6 milliliter per kg, albumin could be used to avoid reaching these parameters. In this protocol that we used before, when the increase in the 20% occurs twice, or increased by 10% occurs 3 times consecutively, and or the rate of infusion reaches 1 liter per hour, here the albumin could be used. Some authors consider the use of the hypertonic saline, and in many trials it showed the decrease in the fluid volume used, and decrease in some trials there was a decrease in the acute compartmental syndrome. But actually, this was on the expense of the higher incidence of development of hypernatremia and acute kidney injury. The computer-assisted device or the decision support mechanisms used by the computers to avoid the inappropriate response of the physicians to the urine output. According to the urine output with the targets applied to in the patient, the computer system propose the decrease or increase in the volume of resuscitation. Red cell destruction occurs to a variable extent. There is a direct destruction of the red blood cell. There is delayed destruction of the RPCs that occurs due to fragile RPCs and the effect of the smaller destruction. However, the magnitude of red cell destruction is dependent on the depth of the burn rather than the surface area of the burn. So the blood transfusion, whole blood transfusion, is indicated only in full thickness burns more than 20% of the body surface area, and the larger the area of the third-degree burn that affect the full thickness, the more the urgent the need for blood transfusion. But you should notice that in presence of high hematocrit exceeding 60, this indicates the presence of hemoconcentration, and this indicates the urgent requirements for an electrolyte solution rather than blood transfusion. Blood transfusion only given when the hematocrit is at 60 or below. And as other types of indications in medicine, the restricted blood transfusion protocol is associated with lower mortality and lower infectious complications in burn patients. From the lessons learned during the belly pumping in 2002, there was a low rate of airway complications despite the long transport time. And they attributed this to the use of minimal pre-hospital fluid resuscitation, and this emphasized the importance of control of the pre-hospital resuscitation, especially in the mass casualty incidents. In the mass casualty incidents, the judicious use of the IV fluids is difficult. The controlling the rate of IV fluid administration is difficult. So the technical working group on burns by the WHO proposed guidelines for in the mass casualty index with the use of the oral rehydration solutions for the resuscitation before arrival to the hospital. However, if there is an extended delay in the transport to the healthcare facility, here the IV fluid should be given. This is to mitigate the high probability of the over-resuscitation and the fluid creep when the initial high IV fluid resuscitation were used. On hospital admission, if the burn is more than 20%, then they proposed again in a mass casualty incidents only to use a fixed rate of 100 milliliters per kg, and if it is from 20 to 40 to be oral, and if it is more than 40 to be an IV fluid. When this protocol was plotted against the Parkland and the modified Brooks formula, this is the protocol of fixed rate of 100 milliliters, and from 20 to 40, it includes the oral rehydration. About 40, it includes the IV rehydration. This is 2 milliliters per kg, 4 milliliters per kg. This is modified Brooks formula, and this is the Parkland formula. So it seems that in the range of 25 to 50% burn, this fixed formula matched with the use of the Parkland and modified Brooks formula. However, if the burn area was less than 25%, there was a slight overhead resuscitation, and if it's less than more than 50%, there is a slight under resuscitation. Of course, when it's more than 60% burn, there was a large form of under resuscitation. And this policy of the fixed dose or one size fits all of the 100 milliliter does not fit with the policy applied by the Baxter in the Parkland formula and followed in all formulas later on by the use of the large volume resuscitation in the first 8 hours post-burn compared to lower resuscitation after those 8 hours. However, this policy applied only in cases of mass casualty incidents where there is low resources to be used with the burn. So the fast response with starting easy fluid resuscitation is of great impact on the fluid outcome. The mostly accepted protocol is the use of the lactated ringer solution, 2 to 4 milliliters per kg per cent burn area. Half of the amount are given during the first 8 hours, and the other half during the subsequent 16 hours. Adjust the fluid administration rates according to the urine output with a target of average 30 to 50 milliliters per hour. The over-resuscitation is as dangerous as the under-resuscitation. If large volumes are used exceeding what's called the AV index of 250 milliliters per kg, you should monitor the intra-abdominal pressure and you may use albumin at this stage. Thank you.
Thank you, Dr. Khaled, for this excellent, distinguished lecture about the very, very hard challenging task, which is the fluid management for